Good evening, ladies and gentlemen. Welcome to the question trial class from First Aid AMC course. My name is Rabia, and I'm one of the tutors that has been working with First Aid AMC since 2021. I welcome all of you. We'll be going through some sample questions today to give you an idea about what sort of questions are asked in the AMC MCQ exam. I will be explaining a little bit of tips and tricks about how to navigate through the questions. Let's just wait a couple of more minutes so that maximum number of people can join, and then we will start the session today. I will also give a brief introduction about the First Aid AMC MCQ course, the duration of it, the contents we teach, how we schedule our classes, and how to navigate through the software once you become a part of our team. All right, let's just wait a couple of more minutes. Thank you. All right, so let's introduce the course for today. I welcome you to participate in this recent sample question solvation class, which is a trial class we do before the start of every course, so that maximum number of people have an idea about what we are coming with. So first aid AMC course is consistent of 5 months course, the duration from the time you enroll within the course. And we take maximum of 4 to 5 classes every week. The theoretical part of the classes will be covered by our main course coordinator, Dr. Arshan. So he's the main course coordinator who will be covering all the theoretical parts of the AMC MCQ exam course. And a weekly sample question discussion classes will be taken by a number of tutors which are associated with course. I'm one of those tutors. So we will be taking at least 2 to 3 sample question classes in which we discuss different questions that comes in the previous exam and how to navigate through those questions, how you are going to save time in solving those questions, how to exclude the answer by using the exclusion method, and we will discuss the topics which are very much important for your exams in details as well. So I was also a student of first aid AMC course. I passed my exam, the MCQ exam in 2021. And then my clinical exam, again, I used the AMC clinical course with first aid AMC. I took a course with them and I passed my clinical exam in the first go as well in 2022. And I've been working in Australia since 2023. So I will also guide you about how the Australian system works and how to follow the guidelines which are used very frequently in Australian health system as well. For your exams, the main source that they recommend is the John Murtagh, is the Book of Medicine. It not only covers the medical part of the medicine, it also covers the surgery. It also covers pediatric medicine and surgery, and your obstetric and gynecology as well. So John Murtagh is your first source that Dr. Arshan will go through in your theoretical class. He will go through different systems, and then we will be discussing about the questions. Other than John Murtagh, you will see a lot of the tutors using guidelines from RACGP, which is the Royal College of General Practitioner in Australia, RCH, which is the Royal Children's Hospital, for guidelines regarding pediatric medicine and surgery. I utilize a lot of resources from South Australian Health for because they have the best resources for obstetric and gynecology questions. Health Direct could be used. This is also a good source for your guidelines. Some of the topics will be covered in Kaplan, which is a good source for emergency medicine and surgery, and MedBullets as well, which has good comprehensive topics for hematology, and OrthoBullets as well for your orthopedic questions. Before going through the questions in this class, I would request that whoever has any questions during my class, so I would advise that please use the chat box, and I will try my very best to satisfy your questions. Okay. All right. Are you guys ready? Should we start? Dr. Almerta, is my voice better now? I've tried to increase the volume. All right. Now, during the class, if you don't understand a particular part of the question, you can just let me know in the chat box, and I will go through the question more slowly. But once you become a part of our course, after 2 to 3 months, we will pick up the pace so that we can train you guys about how to solve the question in 115 minutes as well during your exam time. Okay? All right. Now, do know that the AMC exam is just like any other um, medical entrance exam. It has its difficult parts. It has its easy parts as well. It doesn't mean that this exam is not possible. It is quite possible exam, but you just need to learn how things go and how they approach the things in according to Australian health guidelines. And then it will be very easy for you to train yourself before sitting the exam. And if you do pass the exam, it will become very helpful when you start working in Australia health system. All right. I'm having a very good connection here. Do check on your end if anything is problem there. All right. First question is, a man came from Thailand with complaining of not feeling well. Now, during my class, you will notice that I will highlight a lot of things and I will make stars near the important information as well. So that means that I'm highlighting the important information and we should be putting more attention towards that part. He developed fever, retroorbital pain with aches and pain all over the body. Later, he had a rash, also conjunctivitis and arthralgias. COVID test was negative. What is the provisional diagnosis? Your options are malaria, meningococcemia, dengue fever, and typhoid fever. Now, keep in mind, this person is having a traveling history, right? So all of these can happen or can be contracted during the travel, but you need to know about the sign and symptoms of the diseases they have mentioned in the options. So fever, pretty much in every one of them, fever happens. Retroorbital pain, aches and pain, pretty much happens in everyone. Rash can happen in all four of them, but the development of rash duration is a bit different. More commonly here, the retroorbital pain and arthralgias, and then conjunctivitis. These are symptoms that are most commonly exhibited by patients who have contracted dengue fever. So your option is, the correct option is dengue fever, which is absolutely correct. Why it's not malaria? Malaria do cause high-grade fever, rash, aches and pain, but it doesn't cause bone pain a lot. Bone pain is more dengue's, dengue fever's symptom. Meningococcemia will present with the rash, but your patient will be much more sicker and non-blanchable rash. They will describe the rash to you as well. Typhoid fever, step-ladder pattern fever will be there. Patient will have majority of the times, not always, but majority of the patients have GI symptoms. And then the type of rash they have is a big spots on the body. It's not a rash, like a disseminated rash, but there are big spots on the body, especially on the abdominal region that are called rose spots. And it's the sign of septicemia and typhoid fever as well. So your correct option is dengue fever. All right. Now, these I have taken from your John Murtagh. So you will be given a soft copy of the latest edition of John Murtagh. It's a book of medicine, as I explained before. And in every part, they have everything that comes in the exam is from this book. If you know this book, there is no way that you will not be able to pass the exam. All right. Let's start with malaria. So malaria, we know it has a different incubation period as well. So your symptoms can start after 7 to 14 days of traveling back from the country where you have contracted malaria. Can present up to 2 years, that's very rare. And it can masquerade as several other illnesses because its constitutional symptoms are very similar to all of the other septic diseases. So because it starts with the fever, lethargy, aches and pains, and then it will define its other features as well. But if you have a traveling history, you should know that with the traveling history, malaria should be in the top of your mind if the patient is coming from an area of high risk for malaria. What are the clinical features? So you can have high fever, rigors and chills, sweating, headaches. It usually has a very abrupt onset. Sometimes can have atypical presentations like diarrhea, abdominal pain, and cough. So in a patient who is traveling from somewhere, it's not necessary that you can diagnose the patient as dengue or malaria on spot away. We need to perform different investigations to rule out different diseases, right? And malaria is very important to be ruled out in those patients as well. So what we do is it should be treated because it can lead to death. So the first investigation is that you do a thick and thin smear of the blood that detects the parasites. If those tests doesn't come back with the malaria, but you're highly suspicious of it, then you need to order a PCR test or an immune chromatographic test that can also show these are very sensitive tests, so you will be able to see the results straight away. Malaria fever has a very particular pattern as well. It has a relapsing pattern. So your fever will get better, then you will become febrile again. It has a remitting, relapsing pattern. So you will be able to differentiate it from typhoid fever. Typhoid fever has a stepladder pattern. So it's easier to differentiate between malaria and typhoid based on just the fever pattern. Treatment, we need to admit this patient to the hospital, isolate them, make sure that you rule out a G6PD deficiency because they can go into aplastic crisis. And it's just a symptomatic treatment. We give fluids, and we don't give the drugs that are used for prophylaxis because most of the time patients who are traveling to areas which are high predominant in causing malaria, the doctors or the GPs here prescribe prophylactic medications for the patients to take so that they don't contract malaria. But we can't use those medications to treat an active malaria. So the medications you can use is artemether or lumefantrine, or you can use primaquine. Primaquine is avoided in pregnancy, okay? You can also use atovaquone or praguanil. And these medications are all guided by the infectious disease specialist as well. Clindamycin, doxycycline. Clindamycin you can use in patients who are pregnant. Doxycycline and all those above mentioned, they are contraindicated. In kids, you can use clindamycin as well. In very severe or complicated disease, artesunate is an IV antimalarial that you can use to treat the patients. And quinine, the first drug that was used for treating malaria. Now, antimalarials are notorious for causing hypoglycemia, so it's very important that we monitor their blood sugar levels. Next is typhoid. Same incubation period, plus minus a couple of days. It has a very insidious onset. Headache, dry cough, step-ladder pattern. It means that it gradually increases in its intensity over a period of 4 to 7 days. Patient will have GI symptoms like abdominal pain, constipation, diarrhea, very common as well, and a rash, which is the rose spots on the body, especially the abdominal area, is the sign of septicemia in typhoid fever. Plus minus splenomegaly will be when the patient is quite sick. So the triad is stepladder type of fever, abdominal pain, relative bradycardia will happen, because of the septicemia. So remember, if a patient is coming with the travel history, with GI symptoms and fever that is increasing in intensity, and patient is having relative bradycardia, think about typhoid. Previously, typhoid, there used to be a test that was used for it, but serology is not helpful anymore. Typhoid blood and stool culture is imperative. So when the patient gets febrile blood cultures, and when their abdominal symptoms start, stool cultures, and they should be at least 2 to 3 blood cultures. Treatment, we use antibiotics because it's caused by a bacteria. Azithromycin, ciprofloxacin. Either of those can be used for 7 days. Now, dengue fever. Dengue fever is also known as the breakbone fever. So as I said before, the myalgias is common in every fever, but patients who are having arthralgias on top of myalgias, meaning they have deep bone pains, you should be thinking about dengue. Dengue is also very common in the southeast part of Queensland as well. It doesn't matter if the patient has traveled from abroad. If they're moving from the south part of Queensland as well, you should be suspicious about this. Kindly don't use the screen with, it just causes distractions, if you would please. All right. Clinical features, again, abrupt onset of fever, headache, nausea, retroorbital pain, also very common in there, severe back pain, severe joint pains, and then the type of rash in dengue fever is maculopapular rash. Very common on the trunk, but it's also very common on the limbs as well. When the patient, because one of the complications of the dengue fever is patient can go into DIC shock, right? So they can have, on top of the maculopapular rash, they can also develop a petechial rash because of this thrombocytopenia. And then very rare but a mortal complication of the dengue fever is the hemorrhagic form of the fever, which is the DIC itself, where patient goes into shock, and then they are coagulopathic as well, and they start bleeding from everywhere because the platelets just dropped in number. Prevention for every transmittable disease, especially which has a vector in it, it's just avoid with the long sleeves, making sure that you're having mosquito nets on top of everything. Diagnosis is we do serology for dengue fever, but serology can be positive on any day. It doesn't matter. You have to do the serology on the first day that you're suspecting the dengue fever is developing in a patient. And if a patient has very severe dengue fever, your full blood count will show that the white cell count and the platelet count has decreased, especially in the hemorrhagic form of the dengue fever. Sorry. Unfortunately, there is no directed treatment for dengue fever. It's all symptomatic. So lots of fluid, analgesia, but it's advised to avoid the antibiotics, aspirin, NSAIDs, and corticosteroids because this is basically an immunocompromised state and it worsens the effect. All right. Any question, guys? You can use fluoroquinolones for typhoid, but azithromycin, clarithromycin preferred. Any question, guys? So I've given you these 2 links. These are the Royal Australian College of General Practitioner guidelines regarding a patient who is coming back, a traveler who is coming to you with fever. So differentials of it, how to investigate it, everything is there. All right. Doses are not really important for AMC exam, Dr. Rahul. Yes, it is all given in John Murtagh. I will look when you will be with us during the course. We will tell you about what sort of doses you need to remember. But the doses for antibiotics not necessarily important for the exam. They don't ask about it. You should know which antibiotic to use, but the doses are not important. Some of the topics, majority of it is covered from John Murtagh, Dr. Aksa. But there are some topics that you need to cover from Kaplan, MedBullets, OrthoBullets, and you need to go through the guidelines as well to see the approach of it. Most of the time, the John Murtagh is quite on point with the approach, but sometimes there are some topics that we will let you know during the course that you need to study this from here as well. It has directed a different course to it. Okay. All right. Next question. A patient presented with complaints of staining of his clothes from backside because of foul-smelling discharge. This is the 4th time he had it. He's really concerned. On examination, you found a sinus with hair and purulent discharge. What is the advice for this patient? Get long-term antibiotic, daily testing, don't wear tight underwear, try to keep the area dry and clean. Can anyone tell me what is the diagnosis we're dealing with here? Very good. Pilonidal sinus. Now, the patient is concerned because he's having recurrent infection within the pilonidal sinus. And on your examination, you found the sinus and it's filled with hair, and there is some discharge coming from it. So the advice to avoid recurrent pilonidal sinus, what would you think about in a patient who has it again and again? What is the basic advice that will prevent a pilonidal sinus from being infected again and again? Long-term antibiotic, it doesn't have an end goal, right? You can fix the infection, but what about the sinus? It's still going to be there, right? And it will still be a source for infection again. Daily dressing, it's not a wound, it's a sinus. If you put a dressing on it and don't let it dry, it's going to become more infected, right? Option C, don't wear tight undergarments is a good option, but it's not the end goal again. So the best advice you can give this patient who is dealing with recurrent infections of the pilonidal sinus is, you need to keep the area dry and clean, right? Get rid of the hairs. Make sure that you have cotton underpants on. Make sure that you're moving around and not sitting on the bottom for a long period of time. These are the things that will prevent infection of the pilonidal sinuses. So your correct option is D. We need to keep the area nice and clean. The pilonidal sinus won't be a bother if it's nice and clean and not getting stuck up with the hairs and gunk of the skin as well. Pilonidal cyst/sinuses. It's for both of these things. There are several steps that we can do. Regular washing and drying of the buttocks to keep the area clean. Losing weight so that you're not putting a lot of pressure on that area. Avoid sitting for too long. Again, same thing to keep the pressure off the area. Shaving their hairs around the buttocks once a week or more, or you can use a hair removal product or a laser as well to make sure that the hairs are not getting stuck inside the sinus and becoming a source for the bacteria to grow on. This is again from JM. Recurrent abscesses and discharge in the sacral region at the upper part of the natal cleft can be caused by a midline pilonidal sinus, which often presents as a painful abscess when it's infected. Once the infection has settled, we know for every abscess, we need to incise it and drain it. Otherwise, it's not going to go away with just antibiotics. We need the only thing that can prevent it from happening again is that you keep the area nice and dry. The other option you can give the patient is the surgical excision of the whole sinus tract. That will prevent the sinus getting infected in the future as well. Again, RSCGP point for what practice we use for managing the pilonidal diseases. Give me 1 second, guys. I will be back in a minute. All right. Next question. A 55-year-old school gardener was diagnosed with schizoaffective disorder. What is the cause for the organic pathology? Age, auditory hallucination, or daily school presence? In this age group, it's common to get a schizoaffective disorder. We'll go in a bit of a detail about what is a schizoaffective disorder. What they're asking you about is what can be one of the following causes that can lead to a schizoaffective disorder in a patient who is a school gardener. So this is a very easy question. Schizoaffective, as the name indicate, the first part is so, as the name indicates, the schizoaffective part of the schizoaffective disorder, the schizophrenia, that means that patient have hallucinations, whether auditory, visual hallucinations. There is disturbances within the speech of the patient and the behavior of the patient as well. And there are other negative symptoms that can lead to a psychotic episode in the patient. So they're basically asking you, what is the organic cause for the psychotic episode in a patient with a schizoaffective disorder? And among the three mentioned, we all know that the most important one is the auditory hallucinations. Daily school presence is not the organic pathology. What is that going to give us information in a patient who has schizoaffective disorder? It doesn't. Age is, these patients can also manifest schizoaffective symptoms at a young age of 40 as well. So age is not a determinant here. Because age is not a determinant here, it can present in a lower age group as well. Auditory hallucination is pathognomic for it. You can't diagnose a patient with schizoaffective disorder if they don't have any sort of hallucination. Isn't auditory hallucination a presentation rather than a pause, ma'am? I agree with you. It's a presentation rather than a pause, but the cause for schizoaffective disorder can't be described by age and daily school presence. If you guys know what I mean. It doesn't define it, right? So among these two, I would still pick up a presentation that has more relation with the disorder itself. All right. Now, a lot of things I have given over here. Let's go through the first one. These are all the links where schizoaffective disorder is very well described. I'm just using a couple of those sources with you guys. Just a minute. Share my screen with you guys. Are you guys able to see the screen? All right. Now, schizoaffective disorder, it's a mental disorder. It has two parts of it, schizophrenia part of it and the affective part of it as well. So it is characterized by a major mood episode. Either the mood will be in manic, which is hypermania, or it will be depression, where the patient will be more sad. And that co-occurs at the same time with the symptoms of schizophrenia. There is limited studies about the prevalence, but it's more common between young age group and frequently in female rather than males, whereas schizophrenia more common in male. Sorry, Dr. Faika, this is one of the links I have shared in the class. I will go back to it and you'll be able to see. Comorbidities, or where is it? Diagnostic criteria. So when you come across a psychiatric illness, there is a diagnostic screening criteria for it, which is the DSM-5 criteria. So the first one is an uninterrupted period of illness during which there is a major mood episode that we talked about in the definition, concurrent with schizophrenia symptoms. The major depressive episode should include a low mood, okay? Criteria B is delusions or hallucinations should be present for at least 2 weeks in the absence of a major mood episode. So both of them not at the same time, because depression can cause, in a very severe form, can cause hallucinations and psychotic episode as well. So when you are having a major mood episode, if you're having delusions in a patient of schizoaffective disorder, those delusions will not count in the psychotic part of it. It has to be a separate manifestation when the major mood disorder is not manifesting itself. So 2 weeks of at least delusions or hallucinations in the absence of major mood episode. Symptoms that meet the criteria for major mood episode are present for majority of total duration of active and residual portion of the illness, which is patient should manifest at least symptoms for 6 months before you can diagnose them as well. And mood can be a bipolar type and depressive type. Bipolar type in the manic episode. Depressive type is just the depression part of it. Okay. I'm trying to open this, but it's not letting me, it's not letting me use that. All right. Is that clear, guys? So that's schizoaffective disorder for you. Now, you can also go through this from Better Health, or there is a research done by Mayo Clinic for the schizoaffective disorder as well. But this is the last one that I have shown you. This is the Royal Australian New Zealand College of Psychiatry, and this is their guidelines for that. All right. Let's move on to the next question. A female with 29 weeks of gestation presented to emergency department with the symphysiofundal height of 35 weeks. On examination, the uterus was tender and unable to palpate the fetal parts. Mother is O negative. What is the reason for the current findings? Patient is having a baby with hydrops fetalis. It's a multiple or twin pregnancy. It's an antepartum hemorrhage. Excellent. So when a patient presents with emergency department and you have seen that her duration of pregnancy is not coinciding with the symphysiofundal height, it is more than that, and the uterus is tender and you're unable to palpate the fetal part, the first concern should be patient might be having antepartum hemorrhage, which is placental abruption. Hydrops fetalis, yes, the symphysiofundal height will be more than the gestational age of the patient, but fetal parts are still palpable and the uterus is not tender. Multiple pregnancy, again, yes, symphysiofundal height will be more than the expected duration of pregnancy, but the uterus is not tender. And fetal parts are palpable. More than one fetus parts are palpable. So you're able to do that. The only concern is when the uterus becomes tender and you're not able to palpate the fetus and they're coming with pain, abdominal pain. You should be concerned about a placental abruption. Very good. So your answer is antepartum hemorrhage, and the type of antepartum hemorrhage that we're talking about is placental abruption. Now, this I have taken from your JM as well. It's from the gynecology and obstetric parts, okay? Placental abruption is, most of the time in placental abruption, there is concealed bleeding. So for example, let me just draw this picture for your better understanding. For example, this is the uterus, right? And this is the placenta. Abruption is when the part of the placenta is detaching from the uterine wall. So you might have bleeding just between the placenta and the uterine wall there. And that is irritating the uterus, causing the patient to have abdominal pain. And when you palpate the uterus, it's tender. When it's a big bleeding, you won't be able to feel any fetal parts in that area as well. That's why they couldn't palpate the fetal part and it was tender. Does that make sense? When the placental abruption, the placenta fully detaches and there's a lot of blood within the uterus, then you will have reveal bleeding as well. But reveal bleeding is more common in placenta previa rather than placental abruption. So it's a retroplacental bleeding from a normally situated placenta resulting in detachment of a segment of the placenta from the uterine wall. Patient presents with the mid-abdominal pain, bleeding pervaginally, And if it's not bleeding, it's a concealed bleeding. A very tense and tender uterus, which is large for dates, and signs of hypovolemic shock. It can range from mild to severe, and it's a obstetric emergency and the most common cause of obstetric coagulopathy as well. So you need to admit the patient to the hospital. We need to make sure that we have resuscitation ready for the mother. So 2 big IV cannulas within the mother. Take test for full blood count, coagulation profile, Kleihauer to define if there is any change between the fetal blood and maternal blood, blood for cross-matching, kidney function and electrolytes. Then you do a CTG for fetal assessment to determine their heart activity. If it's very high or if it's very low, that indicates fetal distress. And you also need to do CTG to find out if the baby is alive or not as well. Then we do an ultrasound examination to see the uterus, the contents, to rule out placenta previa and the presence of any placental clot as well. If the patient is in hypovolemic shock, then we treat the patient for that. And if the patient is less than 34 weeks pregnant, we make sure that we give them steroids to help the baby's lung mature. And the objective is to aim for vaginal delivery, but if the patient is hemodynamically unstable, we go for a cesarean section. Is that clear, guys? Any questions? All right. All right. So the other cause for the antepartum hemorrhage is placenta previa. And placenta previa means placenta is in abnormal position. So the placenta is supposed to be away from the cervix, but in placenta previa, the placenta creeps towards the cervical opening. That's why the patient with the placental previa antepartum hemorrhage have revealed bleeding. And there are different classifications of it. So the classification is based on the location of the placenta as well. Principle of management is basically the same as placental abruption or resuscitation, making sure that we are taking blood tests, making sure a CTG is being done for fetal monitoring, ultrasound to rule out what sort of it is, and if making sure the mother is not an anti-RH negative mom. And in placenta previa, if it's one, then in a very controlled environment, making sure that we have a pediatric ICU available. We can do a vaginal delivery, but most of the obstetrics, they go for a cesarean section because it's much safer for both the mother and the baby because it's a controlled environment and the bleeding can be managed. All right. Okay, let's move on to the next question. Patient is taking carbamazepine, well-controlled seizure, so they must have some sort of epilepsy. They took NSAIDs recently for some pain, now presented to emergency department with ataxia and some neurological problems. They didn't define what it is. What is the reason for this patient having these symptoms? Option A, stroke. Option B, carbamazepine toxicity. Or option C, cerebellar tumor. Okay, let's go through our options. Let's start from the bottom. Cerebellar tumor, sure, ataxia would be there, but we need some more evidence for other neurological symptoms as well. what sort of symptoms you would expect for a patient to have with cerebral tumor. So ataxia is one of that. What else you would expect? Can anyone tell me about it? Very good. It's an intracranial tumor. Very good. Headache. Very good. Nystagmus or diplopia. Very good. Balance problems. Very good. Gait, balance problems, all the same. Very good, Dr. Amal. Dysdiadochokinesia. Very good. So you will have more defined neurological symptoms and physical findings for us to define a cerebral tumor. Just because they have ataxia doesn't mean that they have a cerebral tumor, right? We need to rule out other things as well. Again, for stroke, in AMC MCQ question, they will give you very clear neurological symptoms as well. Plus, if they were going for stroke diagnosis, they will define the age of the patient. They will define the risk factor of the patient in the question. And they will give you a detailed neurological symptom. Plus duration as well. Because, we can't define a stroke if it's not persisting more than 24 hours, right? So they will give you all of these symptoms along with age, risk factors for you to define stroke properly in an AMC MCQ exam question. They have just given you one clue here, that they were taking some medications because of the epilepsy. They were well controlled on it, but they took some NSAIDs. Now they're presenting with just one symptom. So if you know that they are taking a drug that can cause neurological symptoms and they haven't given you any risk factor or any detailed neurological examination, go with the drug. Okay, that's a tip for the exam. Does that make sense, guys? They will give you clear-cut clues in the question about what sort of diagnosis you're going to be having. Okay, for cerebellar tumor, it just potentiates the effects of the carbamazepine. That's why the patient is presenting with carbamazepine toxicity. In stroke question, as I said before, risk factors will be defined, detailed neurological examination would be defined, and symptoms, durations will be defined. In cerebellar tumor, again, detailed neurological symptoms will be defined. It won't be a vague history. If you have something like this where they have given you a clue about a drug and the patient is presenting with some symptoms, think about the culprit being a drug. Okay? All right. So your answer is carbamazepine poisoning. The most common dose-related adverse effects is diplopia and ataxia. Can cause some GI effects as well because it's a drug that controls the epilepsy. It can cause in its toxicity unsteadiness, drowsiness. It has some electrolyte effects as well, like hyponatremia and water intoxication. It causes some blood dyskeresis as well. And when it's given with NSAID, that just potentiates its effects. Okay? All right. Next question, guys. A man 45 years of age diagnosed with, look at this, when they want you to diagnose a particular disease, look how much information they have given you. So age, diagnosed with 1, diabetes, 2, hypertension, 3, hypercholesteremia. Now they presented to emergency department. This man was brought by his son as he was confused and he has dried mucous membrane. So they have given you 2 presentation symptoms. On examination, he was tachycardic, blood pressure was low. Also had a fever. He ordered lab investigation on which blood sugars are high. with decreased urine output. What is your provisional diagnosis? Diabetic ketoacidosis, hyperosmolar hyperglycemic syndrome, delirium, or gastroenteritis? Okay, excellent to everyone who is answering B. Now, for people who are going with diabetic ketoacidosis, can anyone tell me what needs for a ketoacidosis diagnosis? What are we missing in the question about ketoacidosis? Very good. We are missing the ketones, right? They haven't given us any information. They have given us very detailed information about the patient, about the past medical history, about the symptoms of presentation, examination, about the lab investigation findings as well. They have given you very clear diagnosis in your question. The one thing they have not mentioned for diagnosis of diabetic ketoacidosis is ketones. If they're not there, does that mean it's ketoacidosis? Can we define diabetic ketoacidosis without ketones? Without acidosis? No, right? It's a diagnostic criteria for it. So what's the other option we have that this patient is fulfilling all the way? What's the other option we have? High blood sugars. Very good. So it's high, and decreased urine output. Low blood pressure, tachycardia. So we know this is hyperosmolar hyperglycemic syndrome. Does that make sense, guys? If they are giving you very detailed things in the question, please make sure that every option has a diagnostic criteria that is being fulfilled. So why we are not selecting diabetic ketoacidosis? Ketones are not given. pH is not given. We don't know whether patient is in there or not, right? Hyperosmolar hyperglycemic, we know they have mentioned high blood sugar, decreased urine output. All right. It could be delirium as well, but they have specifically asked for provisional diagnosis. It could be gastroenteritis leading to the hyperosmolar hyperglycemic syndrome as well, but they ask for provisional diagnosis. Fever can be look, when a patient goes into a DKA and HHS, there is always a trigger for it. And most common trigger for both of them is infection or missing the insurance. Patient is in shock. That's why they have decreased urine output. Usually in hyperosmolar hyperglycemic syndrome, they will have initially increased urine output, but it will become decreased eventually. Clear, guys? All righty. Okay. Vital signs related to hyperosmolar hyperglycemic syndrome is tachycardia, orthostatic decrease in blood pressure, hypotension, tachypnea, hypothermia if infection is present. Physical findings are because of the high amount of sugar, dehydration, and electrolyte imbalance, it leads to altered mental state, which is delirium basically, lethargy, ill appearance, dry mucous membrane, sunken eyes, decreased skin turgor, poor capillary refill, weak thready pulse, anhidrosis, decreased urine output, and cough. It's more associated with mortality than your diabetic ketoacidosis. I have given you, yes, it's because you have so much sugar in your blood, you don't have any volume to it left, right? So you have dehydration symptoms. And with dehydration comes electrolyte imbalance that produces the further complications in HHS. The only treatment for HHS is getting the blood sugars controlled and making sure that we are resuscitating with lots and lots of fluid. So this is the RACGP, hyperglycemic hyperosmolar syndrome. Go through it, guys. Now it's 8:30. Let's go on a 10 minutes break before we complete this. Are you guys enjoying so far? All right, I'm very happy. All right, so let's take a 10 minutes break. Get something to eat, get something to drink, relax a little bit, and then we'll come back and crack the rest of the questions as well. Okay? Thank you, guys. 10 minutes break, please. All right, class, let's start again. Are you guys able to see the screen? Okay, all right. Next question. A 6-week-old infant was brought by parents because of tilting of her neck to one side. On examination, there is a mass you can see on the lower lateral part of her neck. What is the most likely diagnosis? Cystic hygroma, thyroglossal cyst, lymph node enlargement, or sternocleidomastoid muscle tumor. All right, we're having mixed answers. Let's go through the options one by one, okay? Thyroglossal cyst is not a correct answer. Why? Can anyone tell me? Very easy. It's a midline tumor, right? So you will see a mass in the midline of the neck. Lymph node enlargement can be there, but lymph node enlargement will not cause head tilting or torticollis. Right? Same is with cystic hygroma. Cystic hygroma is very common in 6-week-old infants. Do present with the mass on the lateral part of the neck, but they don't cause the tilting of the head neck to one side. That is very, very commonly associated with the sternocleidomastoid tumor. Is it clear, guys? Because it's pulling, it's within the muscle itself, it's a muscle tumor. So it's pulling and it's causing torticollis. That's why the tilting of the neck to the side. Correct answer. So sternocleidomastoid tumor and fibrosis, it's in infants, which is less than 1 year. It's a hard, painless lump within the sternocleidomastoid muscle. It causes the tightening and shortening of the muscle. That's why there is torticollis. Head turned away, but tilted towards the tumor. Just remember that. It's very important. Usually not observed at birth, can appear 20 to 30 days of age. Restricted head rotation to the side of the tumor because of the shortening of the neck muscle. The good thing about sternocleidomastoid tumors that they're not very serious. They resolve spontaneously within a year. So the only care we need to do is a proper physiotherapy session so that the muscle doesn't become shortened and it grows properly. So the mother or the carer should frequently massage the lump, rotate the head of the baby, to the side of the lesion, and then flex away from it. And it's done a couple of times a day so that the muscle is active and it's not shortening as well. If it's persisting, then obviously we need to do surgery, and it's best done before 12 months of age. Older children do present with torticollis and a tight, short, fibrous sternocleidoid muscle. And there is also hemihypoplasia of the face and wasting of the ipsilateral trapezius muscle as well. I think there is a type of a syndrome that is causing all of this. I don't remember the name on the top of my head, unfortunately, but this also requires surgical repair. Thyroglossal cyst, very, very common neck swelling, mostly midline, moves with the swallowing and the protrusion of the tongue, very prone to infection as well, and it causes abscess formation. So if there is infection and abscess formation, antibiotics and incision and drainage is the treatment. Cyst and extract are best excised before it becomes infected. Lymphatic malformation or cystic hygroma, also known as lymphangioma. They're soft tumors on the side of the neck, it can be on the face, it can be in the oral cavity. They resemble cluster of vesicles and often are poorly localized as well. Some can have hemangiomatous inclusions in there, so they appear with red spots. If they're located in the floor of the mouth or the peripharyngeal area, then airway compromise danger is always there. So surgery is advisable in those years. Cervical lymphadenopathy can be caused by the infection, can be a cause of the insidious tumor, blood disease as well. But it's a hard, painless lump, or it can be a soft, painless, rubbery mass as well. If it is painful, that means it's because of the infection. Many causes, as I said, sorry, from local infections to the lymphoproliferative disorders. Usually the malignancy ones are in the supraclavicle fossas, and the primary tumor is below the clavicle. But if it is rubbery, tender, and multiple, it's infection. If it's soft, it could be infection or sarcoid. If it's rubbery and painless, it's lymphoma. If it's hard, then it's most likely a cancer. So you need to keep an eye on it. If it doesn't disappear after 6 weeks, then we need to do ultrasound and a biopsy of it. Any question, guys? A 75-year-old man presented with 6 months history of a painless lump in lower part of the left side of the neck. He had a surgery 1 year before for the gastric cancer. What is the most likely diagnosis? Adenoma, metastatic lymph node, or parotid enlargement? Let me show you the picture of that person as well. Oops, sorry, let me just move the red part. So this one, this is the So you guys are absolutely right, because they have given you a cancer history. They said they had the surgery, but they didn't use the word remission. So most likely it's a metastatic lymph node from the gastric cancer. Very good, Dr. Charu. It's called Werker's node, supraclavicular fossa. It can be adenoma, but we have a clear-cut cancer history, so less likely. Parotid enlargement is not present on the neck. It's on the face near the jaw, angle of the jaw. That's where the parotid gland tumor is. Okay, so your answer is metastatic lymph node. There are several lymph nodes associated with the metastasis of the gastric cancer, and they have different names. I just wanted to touch base with you guys about that. So if the metastatic spread of the gastric cancer is to the pouch of Douglas in the females, it is called Blummer shelf tumor. If it spreads to the anterior axillary lymph node on the left side, it's called Irish node. If it spreads to the ovaries, that's Krukenberg tumor. If it spreads to umbilicus area, it's a Sister Mary Joseph node. And if it spreads to the supraclavicular left-sided, then that's Werker's node. So that's the Werker's node over there. Clear, guys? Any question? Okay. A young boy of 16 years got burned in a campfire. Brought to the emergency department. Whereabouts are the burn? Thigh, abdomen, and forearms. Oxygen saturation is normal. After administering the painkiller, what should be your best step? Intubate, debride, give fluid, dressing, or tetanus injection. Very good. So we are going through the emergency medicine tried here, right? Airway is okay, oxygen saturation is being maintained. Breathing, they haven't mentioned anything about that, and there is no burns on the chest, so we will assume the breathing is okay. We know these patients go into what sort of shock? Burn patient goes into what sort of shock? Hypovolemic. Very good. So they go into hypovolemic shock very quickly. So we need to calculate the total surface area of the burns and then start administering the fluids accordingly. After the painkillers, guys, make sure the patient is pain-free. Is it clear? And then we can do the dressing and start with the tetanus injections and debridement in the operation theater. But make sure airway, breathing, circulation is, everything is okay before we do that. Is that clear, guys? So we need to administer IV fluids. Let me just open up. This is the Royal Hospital of Children in Melbourne, who have given their guidelines regarding burn management. Let me just share this with you guys. Okay, here is my screen. Are you guys able to see the screen with the examination and initial management on the top? Okay. Like all traumas, pediatric burn, any burn, doesn't matter, pediatric or adult, every burn is managed this way. This was written very well, so that's why I copied from there. Like all traumas, pediatric burn assessment require a primary survey and a secondary survey with the initial aim of identifying and managing immediate life threats. So do not get distracted by the burn injury. Your priorities should be airway, breathing, circulation, disposition, and exposure. Okay, so airway, signs of airway burn / inhalation injury. If the patient has stridor, hoarseness, black sputum, respiratory distress, synced nasal hair or facial swelling, then the airway compromise can happen very quickly. So we need to make sure that airway is secured. Signs of oropharyngeal burn, there is soot in the mouth, intraoral edema or erythema. Significant neck burn can also lead to airway compromise because it can cause a scar, and that can lead to sort of like a compartment syndrome in the neck, leading to airway compromise. If above are present, then you should consider early intubation. If suspicion of airway burns or carbon monoxide poisoning is there, then you should apply high flow oxygen. Protect the cervical spine with immobilization if there is associated trauma. Breathing, full thickness or circumferential chest burns may be required to have escharotomy to permit this chest expansion. It's just like compartment syndrome, but it's caused by burns. Because burn layer becomes very hard and there is little area left for the chest to expand when we're breathing. It also leads to a lot of edema underneath the tissue, leading to a compartment syndrome within the chest, leading to lower expansion and unable to ventilate. So you need to do, like we do in fasciotomy in compartment syndrome, we do escharotomy in patients with circumferential chest burns or neck burns. Circulation. If early shock is present, consider other causes as well, other than the burns. But IV fluid resuscitation is required. We need IV cannula for that. For circumferential burns, please do peripheral perfusion check and need for escharotomy. Disability is make sure that they are not having altered level of consciousness, because if they are, you need to consider airway support and assess the neurovascular status of the limb that is involved in the burn. Exposure, then you do the burn assessment and initial management of the burn. So we calculate the area of the burn, total area, surface area, and this is present in every emergency department. And we just color the area and calculate the region percentage. And based on that, we calculate the fluid required for resuscitation as well. So the first aid in the exposure part of the resuscitation that we're doing, we remove the jewelry, we cool the affected area with saline water, we cover with a plastic sling, we prevent hypothermia. So this is the formula that is used for calculation of the fluid. Never in my last 4 years I have seen this being asked in the exam. It has never been asked. Analgesia is also very important. Full blood count, ABG and ECG, because they can lead to a lot of electrolyte derangement that can cause arrest in these patients. So we need to make sure electrolytes are normal as well. So first aid with facade is the thing that you can use for burn management. Clear, guys? Any question? All right. Next question then. What is the best advice you can give to a patient regarding contraceptives while they're stable on an anti-epileptic drug called phenytoin for seizures? Use a DMPA, which is a depot. Use combined oral contraceptives. Use a implanon. Use an intrauterine contraceptive device, or use a progesterone-only device. So the best option for a patient who is stable on phenytoin for seizures. Very good. Phenytoin is an enzyme inducer. So what it does is it induces the hepatic microsomal enzymes of the P450 system, which reduces the efficacy of the oral contraceptives. So any hormonal method their efficacy will reduce by that. So if your patient will not consider other alternatives and they do want to go with the pill, you have to give them a pill with the higher strength as well. 2 other alternatives to oral contraceptives are more effective, which is subcutaneous or intramuscular medroxyprogesterone acetate or IUCD. Medroxyprogesterone is effective and it also decreases the seizure frequency as well. So liver enzyme inducers, according to the Royal College of Obstetric and Gynecology of Australia and New Zealand, on top of the depot, they do, or the implanon, they prefer an intrauterine contraceptive device because it's easier to manage. They have long duration of contraception and they don't have any hormones that are going inside the system as well. The next choice is a DMPA, and then the choice is male condom. If they are still requesting oral contraceptive pills, then extended regime or tricyclic regime with a higher dose of estrogen is recommended. So So the best option among these, because they have asked for best option, is option D. Clear, guys? The option C is not incorrect, A is not incorrect, but the best among these that has the least side effect in patients who are stable on anti-epileptic for their epilepsy is IUCD. All right. Just some evidence-based guidelines as well. I have taken that part from here. So if you do want to read it, good. If you don't, then that is enough for that. IUCD has less effects than implants. It doesn't go into the system, right? It's just local. right? So Mirena is just going to be acting in the uterus and causing contraception there. Phenytoin there are some studies, that's why I put 2 studies over there. They have studies that shows that they have reduced the efficacy of the implants. That's why I put the studies over there. But still, it's not a bad option to use. Umar Baba again. All right, let's move on to the next question. 87-year-old dementia patient went to a social gathering with his caregiver, suddenly got drowsy and confused. Had previous history of COPD, chest examination, there was nothing. Except on examination, you have found that the patient has suprapubic tenderness. What would be the most likely cause for the presentation? Acute exacerbation of COPD, stroke, UTI, or alcohol intoxication. Again, like I said, in AMC MCQ exam, they will give you very clear clues to choose your option. Here, they have given you a very old dementia patient who has been to a social gathering, and they have their caregiver with them. Sudden onset of drowsiness and confusion. Past medical history of COPD. Chest examination is absolutely fine, but only thing they found was suprapubic tenderness. So we know this patient is sudden onset of drowsy and confusion. There's something going on, right? But examination rule out acute exacerbation of COPD because a patient who has an acute exacerbation will be quite short of breath, tachypnic, increased work of breathing will be there. No past medical history has been given to say, because stroke can present with confusion and drowsiness, but they haven't given any risk factors other than the age, right? The only clue we have, and the patient was with the caregiver, and there was no history of any substance misuse. The only clue we have is suprapubic tenderness. The patient has UTI that led to delirium on top of the dementia patient. Does that make sense, guys? How we have picked our answer in option C? So they will give you very clear-cut clues. It's important that you read your question very carefully. That will help you rule out all the things and go towards your answer. So UTI. UTI can be a masquerade when it presents as a constitutional problem or general symptoms, and sometimes there can be no symptoms at all. But most common symptoms we know is frequency, dysuria, loin pain. Very common in the infants, young children, and elderly, but uncommon in adult women in pregnancy. Not uncommon, sorry. Acute UTI may occasionally present as acute abdominal pain as well. Very common presentation of acute abdominal pain in elderly and in children. Cause of dysuria, they have given you checkpoint. Non-specific symptoms are there: fever, lethargy, poor feeding, failure to thrive, especially in the young ones. But in the elderly, confusion, behavior disturbance, fever of unknown origin is there. And that will cause delirium in the patient. The behavior disturbance, it's the delirium. Especially if you have a vulnerable brain that already has been diagnosed with dementia, they go into delirium very quickly if they have an infection, especially a UTI. Clear, guys? All right. Again, IRCGP UTI guideline. Let's move on to the next question. A male patient, 50 years, presents with sudden severe headache, visual halos, knuckle rigidity. What is the provisional diagnosis? basilar migraine, subarachnoid hemorrhage, posterior circulation stroke, or cluster headache. So 50 years, sudden onset, headache, neck rigidity, visual halos. So this is very good. This is something you don't want to miss in the exam. Subarachnoid, if you miss in exam and in emergency department, your patient will die. So any patient who presents with the sudden severe headache, knuckle rigidity, very high blood pressure, visual disturbance, think about subarachnoid hemorrhage or intracranial bleed in general. Stroke can cause headache, and visual disturbances, but it never causes the nuchal rigidity. That's not associated with stroke. Basilar migraine can also cause, but it's not a global headache. It's a sudden severe unilateral one. Sometimes they can cause nuchal rigidity, but it's very unilateral. They will just say, oh, this side of the neck is hurting. I'm unable to move because this side feels like it's locked. Cluster headache, again, unilateral, but also patients will have lots of lacrimation. Their face on one side will be red. They will also have lots of mucus coming from their nose, and these headaches are more severe in intensity than subarachnoid hemorrhage, to be honest, pain-wise. So your answer here is subarachnoid hemorrhage. Okay, let's go through that. Let's go through migraine first. Migraine with brainstem aura. It was previously known as basilar migraine, not the word that is used nowadays. It has symptoms of the brainstem. So dysarthria, vertigo, tinnitus, diplopia, ataxia, hearing loss, impaired consciousness, plus a unilateral headache. There are different types of migraine as well. Vestibular migraine with the vestibular symptoms. Hemiplegic migraine will look like a stroke, but is not stroke because the symptoms resolve after 72 hours. Even they have a normal CT head and a normal MR of the brain as well. Retinal migraine looks like TIA, but again, normal MR of the brain. And it gradually resolves as well. But retinal migraine, difference from the TIA is that unilateral headache would be there. We have discussed about this. So unilateral, very common. Retroorbital occipital region, intense and throbbing. Very frequent in patients who are not on any prophylactic medication. Patients have auras. They know the headache is going to come. They feel nauseous. They feel some sensory disturbances. Nausea, vomiting is associated with the intensity. Sometimes patients also have triggers, like they have certain foods that cause the migraine to come about, lights, noises, emotional stress. Treatment of the acute attack is that we give paracetamol, make sure that they lie down in a dark room and they sleep. If the paracetamol is not helping and they're feeling nauseous and vomiting again, so aspirin or paracetamol with the antiemetic is helpful. You can also give NSAIDs like ibuprofen. If patient is in emergency department, then you should give IV antiemetic because it also helps with the headache. Or you can give a medication like prochlorperazine. It's also antiemetic, but it also helps with the headache intensity. Alternative is that you can give subcutaneous triptans to these patients or nasal sprays of the triptans, but there are some contraindications to it that you need to watch about, especially in the patients who are on SSRIs, MAO inhibitors, and lithium. Now, if the patient is having recurrent attack in migraines, we need to give them prophylaxis as well. So beta blockers like propranolol, tricyclic antidepressants like amitriptyline, very commonly used. Sometimes anti-epileptics like sodium valproate is also used, or topiramate is also used, but very few patients I have seen on pizotyphine, or methylsergide or gabapentin. Very few patients. To be honest, I have never seen them. Subarachnoid hemorrhage, life-threatening, so you should not miss the diagnosis. Thunderclap, severe headache, most of the time in the neck and the base of the brain area, occipital location. It's localized first, then becomes generalized. So a differentiating point from migraine. Very painful and stiff neck, vomiting and loss of consciousness because of the raised intracranial pressure, confusion because of the raised intracranial pressure, seizures because of the raised intracranial pressure, neurological deficits because of the raised intracranial pressure. Most commonly, if there is an intracerebral bleed, you can have hemiplegia or third nerve palsy as well. CT is the investigation of choice. And lumbar puncture is not necessary if the diagnosis can be made by the CT, but if CT is negative, you can do a lumbar puncture after ruling out high intracranial pressures on CT scan. Sorry. Blood staining of the your cerebrospinal fluid or xanthochromia is a positive feature. So management is you need to send these patients immediately for surgical intervention. If it's a small one, it can be observed, and you have to maintain the blood pressure within a certain limit, and medications are used to control the intracranial pressure as well. Cluster headache, it's very bad, to be honest. It's a proximal clusters of unilateral headache that occur mostly during the early hours of the morning or during nighttime. Patient have retroorbital headaches behind the eyes, rhinorrhea, lacrimation, unilateral headache and pain. You can give you can give 100% oxygen. It has a good response. Sumatriptan can be given along with metoclopramide, or you can do an occipital nerve block. But for patients, because it's a cluster headache, it comes in cluster, you need a prophylactic treatment to prevent the clusters from happening. The most commonly used are the calcium channel blockers, verapamil. Steroids can be used. Lithium is very commonly used. Sodium valproate is commonly used. Methylsergide, I have never seen, but it's a drug approved for the use of cluster headache. So one-sided doses, lacrimation, nasal discharge, and facial flushing on one side. Any question from that, guys? All good? Okay. Let's move on to this one. A young boy, 6 years of age, was standing on roadside with his mom, suddenly wanted to run when the mother holds him by his wrist. Now presents to the emergency department with the pain below elbow. What is your provisional diagnosis? A pulled elbow, a green stick fracture, buckle fracture, or a wrist sprain? So I think we have all come across this. Very common pediatric injury, especially in children who are trying to run, but the parent is trying to hold them back. Green stick fracture, there will be pain below the elbow, but if you pull the elbow, it will be there will be a deformity, right? In green stick fracture, if there was a fracture. Again, in buckle fracture as well. Less likely to be sprain, wrist sprain, because the mother has pulled from the wrist to hold him, and all of the force got exerted at the elbow to stop the child. So that is typical pulled elbow. Oh, sorry. Where was it? Pulled elbow. All right. Are you guys able to see the screen? Are you guys looking at the slides or what are you guys looking at? I don't know what just happened. Presenter view. Okay, sorry about that. Is it better now? Are you guys able to see the whole screen? I don't know what just happened. Okay. Pulled elbow, that typically occurs in children less than 8 years of age, usually at 2 to 5, when adult applies sudden traction to the child's extended and pronated arm. The head of the radius is pulled distally through the annular radiolunar ligament. Sorry, I'm not very good with orthopedic words. So it's basically the head of the radius gets pulled out of its ligament. This one. Crying child refusing to use the arm. Arm is limp by the side or supported in the child's lap. It's flexed slightly. Any flexion when it's done by another person will be vigorously resisted by the child because it causes pain. Forearm is held in the pronated or in mid position. Arm is tender around the elbow without bruising or deformity, whereas in the fractures, you will get bruising or deformity. X-ray is not usually recommended, but we usually do it anyway. So treatment is that you do controlled relocation of the radial head. So what you do is place one hand around the child's elbow to give the support, and then press the thumb over the head of the radius. And with the other hand, you flex the elbow and push the radial held down into full supination mode. That causes the head of the radius to go back into its ligament, and it's relocated again. It can happen again, to be very honest, in children. If it has happened one, the joint is a bit loose, it can happen in a couple of years as well. There's other ways, but this is the most common one that we use in the emergency department. And the way to make the child pain-free is sometimes intranasal fentanyl can be given, or nitric oxide gas is used as well. These are the RCH links if you want to go for the pulled elbow topic from here, but JM was sufficient. It's the same thing that has been written over it. All righty. Next question. Okay. A GP found that there was trachoma. Oh, sorry. Did you guys have any question from the previous one? All right. A GP found out that there was trachoma case in community. 5 kids were infected and 20 contacts are there in the community. What is the treatment the GP recommends for the index case? Give azithromycin, give doxycycline, isolate them, or reassure them? We all know that trachoma is a very, very transmissible disease, and it's very important to control the index cases and the contacts as well. And the thing to do is a safe approach, which is making sure good hygiene is there, washing of the face is there, antibiotics, azithromycin is there, and in severe cases, the patient is being referred for surgery for the repair of the disease as well. So absolutely right, guys. Option A is correct. So this is the RACGP guideline for trachoma, and this is your JM. So trachoma is a chlamydial conjunctivitis that is very common in Australia, especially in outback areas. These are the areas which are near the center of Australia. And in indigenous population, when you start them on antibiotics, there's no need to isolate them. We just need to make sure that they are having good hygiene. Good hygiene, hand hygiene, and face hygiene will prevent the transmission of the disease. So if you're touching your eye and you're touching this person with the same hand, it causes the transmission of disease. Isolation will not prevent the spread of the disease. Where was I? Sorry. It's very common in the indigenous population. The culprit is the Chlamydia trachomatis. It's transmitted by human contact between children and parents, also by flies as well. So what's the point of isolation, right? Especially where hygiene is inadequate. So better improve the hygiene. Most common cause of blindness in the world. Recurrent and untreated disease lead to your lid scarring and entropion, which is the inward turning of the lashes, which disrupts your sclera, causing corneal ulceration, and that leads to visual loss. It is very important that you control the infection in the childhood by giving antibiotics. So you prevent, do community education, give azithromycin, and surgical correction where relevant. Prevention by World Health Organization, they have a safe strategy, which is you do surgery for tracheasis, you give antibiotics for cases of active trachoma and their contacts, facial cleanliness by promoting clean faces to reduce the spread of the infection, environmental improvements to improve overcrowding, water and sanitation facilities. Clear, guys? All right. Any question from this one? Sometimes they ask you about the percentage and contact management. So if you have active trachoma in the community, prevalence in 5 to 9-year-old, and more than 20% contact cases are there, then you treat all patients who are more than 3 kg living in household with children less than 15 years of age. If you have more than 5 but less than 20% contacts, and there is no obvious clustering of cases, then you treat all patients living in the household with children less than 15 years of age. If you have more than 5 to less than 20, but they are clustering, then you treat everyone basically with a single dose azithromycin. If it's less than 5, then within the active trachoma case, you treat everybody. So this is something very commonly asked in AMC MCQ exam based on the percentage of the contact for a contact management. Clustering means they're in the same place and it's a small place with a lot of people. And they know each other and going to each other's houses. No, this is not from JM. That's why I have given you guys here. Dr. Arshan will go through that in detail in his theoretical lecture, but it's something that I wanted to share with you guys as well, just for important information that is frequently asked in the AMC MCQ exam. That's the weight. They just mentioned the weight. So all the kids, all the elderlies, and everyone in between gets treated. Easier way of saying. All right. Next one. A woman went tracking, but then she had a swelling below in lateral to pubic tubercle. Now presenting to emergency department as there is no cuff impulse and that swelling become non-reducible. What is the cause for the hospital admission? Is it an inflamed lymph node? Is it a femoral hernia? Is it intestinal obstruction or strangulated hernia? It's not an inflamed lymph node. She had a swelling, but now that swelling is non-reducible and no cuff impulse. What has that? Hernias. We use this sort of signs for hernias. What is the cause for the hospital admission? It's a femoral hernia. And I agree with you guys. The best option would be to choose strangulated hernia instead of femoral hernia. Because it's a hernia that has become strangulated with no cuff impulse and non-reducible. Let me just, can I edit this? Just edit this one for you. This is, I agree with you guys. This is not. Just not doing. Traction. Okay. Traction causes formulation. So this will, your inguinal ligament and pubic tubercle helps you to guide whether it's a femoral or inguinal hernia. Moreover, in females, femoral hernias are more common, right? So above the inguinal ligament, medial to the pubic tubercle is inguinal. No, she was coming with pain, Dr. Laiba. And below and lateral, it's femoral hernia. There was no swelling. The swelling was there before, but now it's becoming non-reducible, no cuff impulse. That is for hernias. If it was red erythematous, painful to touch as well, then I agree, it could have been an insect bite. All right. Femoral hernias, they are below the inguinal ligament, below and lateral to pubic tubercle. Females, especially those who have multiple pregnancies or has weight loss, often irreducible, most commonly prone to strangulation. Not very commonly presenting, but mostly happens on the right side. Okay. Is it clear, Dr. Zeba and Almitra? So cuff impulse and non-reducibility, if they said the skin changes were there, it was definitely I would have talked about an inflamed lymph node. But cuff impulse and non-reducible, you would think about a hernia. And the option correct was strangulated hernia. Okay. Female over 50 years of age presented to GP clinic with breast pain. On examination, 2 centimeter in size lump. Now pain has subsided. What do you want to do next as her doctor? Ultrasound her, reassess her, do a fine needle aspiration or cytology, or do a mammography? 50 years of age. Any female who has a breast lump and pain needs further investigation. Now, based on age, you will do the investigation, right? You will never reassess in 3 months without investigation. Okay? So, over 50 years of age, highly dense breast, so we do mammography. 35 and less, we can do an ultrasound as well. But for a breast lump, you need to remember the triple test. Always remember triple test. First is clinical examination. Next is imaging. Third one is biopsy. All right, guys. So your option is mammography. We will, because this female is more than 50 years of age, the imaging modality for 50 years with a breast lump is mammography. Okay? Absolutely correct. We will never reassess in 3 months without doing any imaging. If they are presenting with a breast mass, you obtain a history and perform clinical breast examination. So that's your first of the triple test. If the examination suggests no mass, then you repeat the examination 2 to 3 months. That's when you reassess. If they do have an indeterminate lesion and they're less than 30 years, you do an ultrasound. If they're more than 30 years, you can do a mammography. And after mammography or ultrasound, it's a definitive mass, then they need to have a biopsy as well. That's the triple test: clinical examination, imaging, and biopsy for a breast lump. Clear, guys? Any question from here? All right. This is a similar guideline, but it was quite old. This one is a more newer one. I just wanted to put it there for you guys to have a look. You can just do a median age, 30, 35. I would just go with 30. Just go with 30. Density of the breast. It's difficult. What I have read is it's difficult to see a lesion on ultrasound in a very dense breast. That's the reason. I don't know what was the reason behind it, but as you get older, more denser breast, mammography is the best modality to go with. An ultrasound in a 50-year-old, it will be difficult to rule out a mass. All right, next question, and I think that will be one of our last questions. Yes, it's our last question for today. A male patient has diagnosed with chlamydia. Wife is also your patient. Husband had sex with other woman and his wife as well. What is your advice for him? Advise him to discuss with his wife. Tell him that you will have to inform his wife or notify the wife through the pathologist. So this is an ethical question which you will get a lot in your exam. As your GP, even if the spouse is your patient, patient confidentiality comes first. So the best advice would be to advise him to discuss with the wife. After prompting him several times, if the patient still engages, then it's become a legal duty as a doctor to inform the spouse. But not before you have given several times advice to the patient to inform the wife about the condition. Okay? You don't tell the wife directly. You prompt the patient to do that. It's not your job. But after several attempts, they are not listening, active, and wife is symptomatic and don't know where it's coming from, then you have to inform him before informing the wife first. No, you don't. You are not allowed to disclose the patient's results even to the spouse. Okay? So you need to, because it's a sexually transmitted infection, you need to encourage him to tell the wife. In B, you are breaking the patient confidentiality with. Okay? You can't do that. All right? So it depends on the practices. Several practices, according to local guidelines, like in my practice, we gave them at least 6 times, and then we involve the health department, and then a letter goes to the home. The first option would always be to encourage the patient, but after several attempts, if they are not, and you want to tell the health authority about it, yes, that could be a better option to go to. And that brings us to the end of our class. No, we never directly tell them. No, it's not our job. Because if they are your patient, you're breaking the patient confidentiality. All right, so this is the STI guidelines that is used for basically everything in Australian. Sorry, my brain just flipped for a moment. So STI guidelines are used for every sexually transmitted infection. So if you want to study any sexually transmitted infection, you can go through this. Don't go to JM for STI guideline. Sexually transmitted infection is very well written on this. Let me just open up this for you guys and you can see what I'm talking about. So have a look over here, guys. Oh no, what just happened? Okay. Are you guys able to see the screen? STI Guidelines Australia. So STIs, chlamydia, herpes, gonorrhea, hepatitis A, B, HIV, syphilis, trichomoniasis, syndromes, population and situation, everything is written here. So read the STIs testing management and population management from this one, okay? All right, I hope you had a great session, guys. And I hope I was able to help you learn a bit about our course, how we do the classes and how we go through each question, and how the AMC exam basically comes in. Again, it's not a difficult exam, but it's not an easy one. You just need to have an approach about it. And the way you will learn the approach is study the JM. We will help you with the question solvation every week as well. And we will help you, train you to solve the questions very quickly. So I have gone through questions very slowly today, but those who will be on board with us, they will notice that I will become very quick in breezing through questions as we go through each session every day. My name is Rabia. And I'm one of the tutors with Dr. Arshan in this course, in the MCQ course. Yes, no exam is easy, especially any entrance exam. So don't take it as an easy peasy exam that you can do just by solving the past questions. If you want to be a good medical practitioner, you need to have a solid base. And the only way you can make a solid base is go through theoretical classes, get a hold of the guidelines, read through it, and then apply your knowledge to questions. All right, guys. Thank you so much for the session today. I really enjoyed it as well. It was quite great, and you're all very great doctors as well. I'll hope to see majority of you in our next batch. Best of luck. If I don't see you, best of luck anyway for your exams and future endeavors, okay? Thank you so much and have a great night.